All right, well, welcome to Chapter 21, the Neurologic system. I know this is going to be trying for all of us. You're obviously used to my dynamic class presentations in person, and unfortunately, I know you're going to miss my, you know, shining face. I'm going to try something here just to see. Let's see if this will work. Nope, camera doesn't work. Sorry. I guess it just doesn't work with PowerPoint. So you're just stuck with my voice, which is some of you are probably applauding right now. I totally understand. All right, let's move on with the chapter and get through this as quickly as we can. Here are your objectives that you need to learn. As I said before, always go through those first so that you understand what it is you're trying to extrapolate from the chapter. Now, what is the nervous system and how is it organized? Well, it's actually the nervous system consists of two systems, to be quite honest. It's the CNS, the central nervous system, and the PNS, the peripheral nervous system, of which you have the basic component, the neuron itself. Now, the neuron is formed of the dendrites. These are branch-like arms that come off and actually elicit sensation. And it moves that through chemical, neurochemical transmission through the cell and through the complete neuron itself. And as it does, these impulses move through the nucleus of the cell and then along the axon and in the direction of the impulse. And as it does that, it goes over the synaptic gaps that you use chemical exchange. And these chemicals that bridge these gaps are usually acetylcholine and dopamine are key components for these neurochemical compositions. So understand that the CNS, the central nervous system, is comprised of your brain and your spinal cord. Okay, and your brain is further divided into components that we'll get into. And then the PNS, the peripheral nervous system, that's throughout your body, that extends out from your spinal cord. And that includes your 12 cranial nerves, which are extremely important for you to learn, and your 31 dermatomes, which are also important for you to understand. But that, I would honestly say, gets a little bit more detailed. And right now, I'd focus on the 12 cranial nerves. The dermatomes we'll get into more your RN year, okay, at that time. All right. Now, the functions and divisions of the brain, you can see that in table 21-1, and that tells you the different components of the brain. The cerebrum, which is the center of intellect and consciousness. The cerebellum, which is responsible for coordination and movement. Okay, that's why your Romberg test is so important. And your diencephalon, your thalamus, hypothalamus, brainstem. Now, the brainstem consists of your pons and your medulla. So, this is what I was talking about when I talk about the basic neuro component. This is a neuron in itself. You see those branch-like components of the dendrites back to the cell body. And then how the impulse will move along the neural pathway. And that's important to understand and how it works. It's also important to understand the myelin sheath that is around and encases the nerve itself. So think of the nervous system almost like an electrical system, in that the nerves would be similar to electrical wires running through your house. If you had bare wires, they would short out. You have to have the insulation around the wire for the conduction of the electricity to move smoothly along the wire without any complications. Now, that's what the myelin sheath does for you. And when we get into degenerative neurological diseases, we'll talk a little bit more about that. Okay, here's the brain. I already talked about, the cerebrum, the cerebellum, and the various components. And you guys also, this would be your brain stem and how it's broken down. Okay, now understand that the thalamus, hypothalamus, and the lower, as you get more towards the brainstem, it provides extreme components like your respiratory drive. So that's why, the hangman's noose would break your neck right there at that level. So you have to understand that the brainstem, the pons and medulla are important components. All right, here's another aspect of the brain. It just shows you what is done where. Your personality in your frontal lobe, and your vision in your occipital lobe. We already knew that. Your hearing, okay, and auditory receptive. Well, that makes sense. It's over by your temporal lobe because your ears are over there. All right. So just take a look, and you got a rough idea of how the brain works and what works where. And why is that important? Well, if your patient happens to have a TIA or a CVA, and we'll be getting into that. Does anyone know what a TIA is or what a CVA is? No one? No one at all? Okay, well, a TIA is a transient ischemic attack, and a CVA is a cerebral vascular accident. And those are both neurological conditions that can occur when someone has a stroke. Now, depending on the type of stroke they have or the severity of the stroke will determine on whether it's a transient ischemic attack or a cerebral vascular attack. But where the stroke occurs, especially if it's a cerebral vascular attack, that means you're going to have residual deficits. So where that damage occurs, that is damage that's actually occurring to the brain. And that neurological deficit determines where the brain is damaged will determine what goes wrong. So if it's in the frontal lobe, the person could have a complete personality shift. Or if it's on the occipital lobe, they could have visual disturbances. And that could be the neurological deficit that they suffer. All right, not to mention the various muscular deficits that they can suffer for strength and motor skills. And this is the 31 dermatomes we were talking about before. Now remember, what I want you to focus on is the 12 cranial nerves, and that's going to be important for you to know for the PNS, okay, and because as they branch off the spinal cord. The 31 dermatomes are going to be important when it comes to your RN year and assessing patients when they come out of surgery post-operatively. Now, if you look on table 21-2 on page, it looks like 475, there is the list of your 12 cranial nerves, starting with olfactory, which is the sense of smell, optic, which is your visual acuity, okay, oculomotor, which is eyelid, okay, eye movement, pupil size, trochlear, which is your motor extraocular eye movement. This is your interior and lateral eye movement as it occurs. Now, a trigeminal is a sensory corneal reflex. This is what makes you blink when someone or something touches your eye. It's also facial sensation and chewing and biting. Abducens is the extraocular eye movement, okay, and that is more of your lateral eye movement. Facial is the sensory of taste and facial movements. This is when you get them to smile, okay. Now, acoustic, hey, you just do a quick generic hearing test. Can you hear that? That's just me rubbing my fingers together. You might do that close to their ear and see if they can hear it, or you might whisper in their ear. Glossopharyngeal is a sensation of the throat, taste. This is also where you want them to test for a gag reflex. Vagus is the sensory sensation of the posterior tongue, throat, and this is where you might have them swallow. The spinal accessory is shoulders. You have them shrug their shoulders, and the motor tongue movement, you just have them speak. Okay, so that's your 12 cranial nerves. Okay, your last one was your hypoglossal nerve, and you guys definitely need to know those 12. Now, um, so I already talked a little about the neurotransmitters and how that works with the nervous system, and I already talked about the myelin sheath. So you already have a pretty good understanding of the nerve component itself. So how does the peripheral nervous system interact with the central nervous system? Well, it does it through afferent and efferent pulses. Now, it's important to understand, how afferent and efferent work. So I would say that, let me find my place here, that afferent and carries the pulses to the central nervous system, and efferent carries impulses away. So I'm trying to think of how best to remember that. I guess you could say that efferent, the impulses exit. How's that? The impulses exit, efferent, E and E, exit the CNS, where afferent, they're moving at the CNS. So the impulses, the neurological impulses are moving at the central nervous system, afferent. So if you see an A, think at the central nervous system. If you see an E, think exit the central nervous system. I hope that helps you keep them, somewhat, because they can be confusing because they do sound an awful lot alike, afferent, efferent. So now, this is where we get into some fun. Voluntary, the somatic nervous system, right? And the involuntary, the autonomic nervous system. Now here, let's try a little test. When I say go, I want you to hold your breath. Okay, ready? Go. Okay, breathe. No problem, right? Hey, you just held your breath for less than 5 seconds. Now, when I say go, stop your heart. Go. Okay, I don't think any of you complied with my request. Why? Because your heart is wired to your autonomic nervous system. It's going to beat on its own. And there's so many things in your body that are wired to the autonomic nervous system that you have absolutely no control over. You might think you do, but you don't. And that's good, because if you did, there's no way you could control all that. So what we talk about when we get to the somatic, those are voluntary. Boom. I want to move my arm, I move my arm. I want to move my arm away from something, I can. Voluntary movement. Autonomic. It's automatic. You don't really have any control over it. So the autonomic system is now divided into 2 groups. Remember that, because this is where it gets important. The sympathetic and parasympathetic nervous system. Now, when you think of sympathetic nervous system, think of things that gear you up, that really get you going. I'm talking adrenaline rush. Okay, this is a roller coaster ride. This is someone going boo in an amusement park, in one of those scary houses. This is watching a scary. Matter of fact, watch a scary movie and see if your heart rate doesn't go up. This is what happens. Your autonomic nervous system, when you get scared, it's called fight or flight syndrome, and your body gears up. Your pupils, dilate. You breathe faster. Your heart races. That's all getting you ready to respond. Now that response is either going to be fight or flight. But either way, both responses are geared up responses, require your body to be geared up and ready to go. So that's sympathetic, gears you up. Now, parasympathetic. that mellows you out. That brings you down. That smooth, okay? That slows down everything. This is where parasympathetic, right? More digestive stuff going on. Slows you down, takes your time, okay? Sympathetic, boom, heart racing. Respiratory rate increased. Everything gears up. Parasympathetic, everything gears down. Now, you're going to have a neural pathway that will, you can see, you have stimuli. Ooh, you step on a nail. We've all done it. We've all stepped on a sharp stone or something, and you quickly, without even thinking about it, move your foot away. Or you go to grab something on the stove and it's hot, and all of a sudden, boom, you move your hand away. You don't continue to grab it, and you didn't even consciously think about it. That's a reflex arc, okay? And this is what happens. That stimuli goes to your spinal cord, and your body already responds physically before your brain actually, analyzes what happened. And that's just a basic reflex arc. And it's it's important because it's an important safety mechanism. So that's part of the protection. Now, how's the central nervous system protected? Well, if you notice, anything that really needs a lot of protection in our body, we have a tendency to put bone around it, which is kind of good because it kind of creates a cage. Well, hey, there is nothing that's got more bone around it than your brain and your spinal cord. Think about it. It's tightly encased in bone. Your entire skull and vertebral column is nothing but bone. And that's what your central nervous system sits in. It sits in protected inside that bony encasement that is there for its protection. Now, in addition to the bone, we're going to put it inside this durable material. This is what we call the meninges. Now, the meninges have 3 layers. The outer layer, which is a very coarse and durable layer, almost like a burlap sack. It's really thick and durable. We call it the dura mater. Why? Because it's durable. Now, the very thin layer that goes against your brain, because your brain needs to be, caressed nice and gentle. That's a really thin, when you think small, you think pea-like, right? Pia mater. The pia mater has this thin layer that goes against the brain and spinal cord. Now we got to attach these 2 layers with something. So you have this spider-like web, if you would, that attaches between the dura and the pia mater, and we call that the arachnoid mater. And those are the 3 layers, the outermost being the dura mater, the center layer, the connective tissue, being the arachnoid mater, and the very thin, fine inner layer being the pia mater. Okay, now, in addition to the bone, this sac that we put the brain and spinal cord in addition to that, we're going to float it. That's right, we're going to float it in nothing but fluid. So that you now have this fluid cushion surrounding the brain and the spinal cord. And we call that, of course, cerebral spinal fluid. Now, if you were to tap into that, tap through between the vertebrae, through the meninges, into the spinal column where the spinal fluid is, it's going to have a pressure because it's constantly being generated. That pressure, normal, is 70 to 125 centimeters of water pressure. And that's important to measure for cerebral spinal fluid. Of course, you can see all the different layers. We don't need to go into detail about that. You can see the different layers I talked about here, the dura, the arachnoid, and the pia. And that's pretty straightforward. And why so much protection for this? Well, it's because the brain, unlike other cells in the body, cannot regenerate. Brain cells, once they're killed, they're dead for good. They don't regenerate. Now, some nerve cells along the neural pathway of the PNS, the peripheral nervous system, can. Those are known as Schwann cells. But those are not brain tissue. Brain tissue, if you remember, is what you need for cognitive function. The other thing to understand is the nervous system, especially brain tissue, is very, very sensitive to oxygen. All right. Brain cannot survive in an anoxic state. They cannot survive without oxygen for more than 4 to 6 minutes. What we used to learn back in the day was called the rules of 3. And here it is. If you're stupid, you can die in 3 seconds flat. Why? You step in front of a bus, you step in front of a train, not paying attention. You're stupid. 3 seconds, boom, you're dead. Okay, if you make the wrong move. Your brain will die without oxygen in 3 minutes. Therefore, you don't put yourself in a situation that's going to deprive you of breathing, like anything underwater, for more than 3 minutes. Okay? Now, you can die from exposure within 3 hours. Don't believe me? Hey, go to the North Pole, step outside, and see if you're not frozen to death within 3 hours. Hypothermia, you better believe it. Exposure can kill you in 3 hours flat. Okay, now hours make days. You can go only 3 days without water, and you can go up to 3 weeks without food. So just think about that. Seconds make minutes. 3 seconds. If you're stupid, you'll die. 3 minutes without oxygen, boom, you'll die. Okay? And minutes make hours. 3 hours without shelter, and guess what? You will die. Hours make days. 3 days without water, and boom. And then days make weeks. You can go up to 3 weeks without food. So if you're ever in a survival situation, I hope that little tidbit sticks in your head, because it'll help you prioritize what you need to do. And this also proves that I don't have to be in front of you to get off topic. Well, so back to the topic at hand. We need to keep the patients oxygenated. We need to monitor their pulse oximetry. We need to make sure that they don't go anoxic for any length of time at all. So, what happens when we get old, besides babbling into a microphone to you guys? Well, you have a loss of neurons with aging. Yeah, that's right. The older you get, the less your neurological system functions, the less neurological system you have, because you lose neurons. The brain weight drops considerably. Wow, that's probably the only part of me that's losing weight, because it sure isn't working anywhere else. Now, the dendrites decrease, which means those little feelers, so the sensation decreases. You get decreased blood flow to the brain. All these things add up to make, what is it saying? Short-term memory is affected, decreased neurotransmission, increased MOAs. In other words, you're just not as sharp as you used to be. You're just not as smart as you. Now, I'm not saying that old people are dense, and don't any of you think that I resemble that remark, but at the end of the day, they're not as sharp as they once were. And this is something you have to remember. There are various neurological disorders. We're going to cover them all in several of the next chapters. What you really need to take away from this page is the 12 cranial nerves. And you need to come up with some type of mnemonic that will help you remember. If you look on the table on page 470, oh, my bad, on page, 475, 21-2, not 21-1, I apologize, where it lists the 12 cranial nerves. The first 3 start with O, O. And then you got a T, okay, and another T, trochlear, trigeminal. See how the pattern forming here? Then abducens, then facial, then acoustic, take A family, right? And then, right, vacation, you got the vagus nerve down there, go vagus, glossopharyngeal, okay? So, after hours, that's at your abducens and your finally your hypoglossal. Now, what I would say is there are numerous types of mnemonics out there. Just figure out a way to remember the 12 cranial nerves and roughly what they do for you, because you will see it again. All right, prevention of neurological disorders. Okay, well, it is important. These are other chapters that we'll be getting into down the road, so we'll talk about those when we talk about the different types of neurological disorders. Understand that drugs and alcohol have effect, promoting immunization, pesticides, various chemicals. It's all in your book. When it comes to evaluating, remember the neurological evaluation. One of the first most important things is just basic level of consciousness. And it's not on the slide, but you might want to write this down. AVPU, A-V-P-U. Is your patient alert? No. Well, does your patient respond to verbal stimuli? No. Well, then, do they respond to painful stimuli? Okay. Press down on their fingernail. Do a little sternal rub. No. Are they completely unresponsive? If they are alert, are they alert and oriented? Are they oriented to person, place, time, and situation? It's always alert and oriented times 4, not 3. All right. So the first thing you want to know is level of consciousness. Are they alert? Are they oriented? Do they respond to verbal stimuli, painful stimuli, or are they unresponsive? You want to assess the 12 cranial nerves. Yes, that's important. But as we move along, you're also going to learn to do other neurological assessments that are just as important, like the Romberg test. And you guys have all learned how to do the Romberg in 140 LC. Reflexes, I'm not going to lie to you. Eliciting reflexes is not an LPN level skill set. It's not even an RN level skill set. That's a provider level skill set. But understanding what the norms are. So, in how to rate reflexes and how they're scored. So you see, 0 means there's no reflex at all. 1 would be a weak. A 2 out of 5 reflex is a totally normal reflex. 3 might be a little aggravated or a little exaggerated, and then 4 would be hyper exaggerated with potential clonus. And then of course you need to know what the Babinski is. And the Babinski, you can better off just looking at the pictures in the book. I'm sure there's some pictures somewhere on page, it looks to be 484. It talks about the Babinski in the middle of the page. On the right hand side, it shows you the Babinski. And it is a basic, some of you probably had this done, where someone scrapes something up along the bottom of your foot, and your foot will automatically respond. Okay, and what you want is a normal response, and that normal response should be that plantar reflex with the toes curled slightly inward. A positive response would be a basic, which is also abnormal, would be when the great toe bends upward with the smaller toes fanning out. That'd be bad. That'd be bad. Oh, here we go. Picture of it. And that's it right there. Okay? So now you understand that when they scrape something along the bottom of your sole of your foot should automatically toes curl inward. Okay? Toes should curl inward, and your foot should kind of want to point away from it. But the other is a positive, would be your toes fan out. Oh, right? That'd be bad. Oh, now, here are some other tests. Now, these tests, last test is your caloric test. And this is what you're looking for with Dahl's eyes. Now, Dahl's eyes is, you're looking to see if they've got brainstem involvement. And what you do is you turn their head. Now, when you turn someone's head, ideally, what will happen when they're rotated briskly to one side, the eye movement is observed in relationship to the head movement. If the brainstem pathways are intact, the eyes appear to move in the direction opposite that of the head movement. If they're not intact, they will stay straight with the head and continue to move like doll's eyes. Oh, cool. Now, the oculovestibular reflex, also known as the caloric test, this is where they'll take cold water and they'll shoot cold water into your ear. And what that does is that elicits this ice cold water being shot into your ear will elicit nystagmus. Your eyes will start to kind of like, it's almost like they get twitchy. And that's a normal response. All right, because let's face it, no one likes having ice cold water shot into their ear. And so those will tell you if you have brainstem deficits. Both are bad, okay? Both are bad if they come back positive, all right? So understand that, because you don't want to have brainstem involvement. That usually doesn't bode well for a patient's outcome. All right. When you think about assigning CNAs, understand that anyone who has any type of neurological deficits obviously should not be taken care of. That's a higher level care. Vital signs, physical assessments. You guys have gone through physical assessment already. You know that vital signs are an extremely important role. But it's not just important for you in the sense that you just take vital signs. It's important in the sense that you analyze the vital signs. You have to look at the vital signs and say to myself, are those vital signs normal? Or do I have an issue going on? Do I have maybe Cushing's triad, where you have bradycardia, bradypnea, and possibly a widening in pulse pressure. Now, how do you know what the widening pulse pressure is? It's simple. If your systolic is increasing, that's going to give you a hypertension, but your diastolic is actually decreasing. So you're getting a bigger number between the two. Now think about it. Your normal, everyone says, hey, normal, 120 over 80. Well, 120 over 80 is only a pulse pressure of about 40 millimeters of mercury. So you start getting to, twice that, you've got a wide pulse pressure. And that's a huge indicator of some type of neurological injury. And if you add that to decreased respirations and a decreased pulse, all right, you better believe you've got the whole full-on Cushing's triad. You've got some type of neurological issue. The Glasgow Coma Scale. You need to understand the Glasgow Coma Scale. I talked to you already about the level of consciousness. You know how that goes. But Glasgow Coma Scale is yet another way to rate people. 3 categories. Best eye movement, okay, verbal response, and motor response, body. So you need to understand the Glasgow Coma Scale. Now, how best to understand it? Well, it's on page, it appears to be page 486 in table 21-7. The 3 categories, so the lowest score you'll get is a 3, 1 for each category. And you need to understand that, hey, for example, 1 through 4 is you rate your eyes. 1 being that they never open their eyes, 2 being that they open their eyes to pain, 3 being that they open their eyes to sound, and 4 being that, hey, they open their eyes spontaneously just when you enter the room. That's a good. The higher the number, the better. Okay, so they get a 4. And then motor, now, I go to verbal before motor, because think about it like this. You have 4 categories in eyes, right? Now, you have 5 categories in verbal. Where do you talk from? Your mouth. Well, your mouth is just a little bit bigger than your eyeball, isn't it? Yes, it is. So that means you have 1 more category. And then your whole body, right, is bigger than your mouth. So that means you have 6 categories. So if you just learn it like that, eyes has 4, verbal has 5, motor has 6, so it's a total of 15. So the best you can get is a 15. The absolute worst you can get, if you're dead, is 3. So you might want to learn the Glasgow Coma Scale. All right? I already talked about level of consciousness. We already talked about AVPU and how to do that. Pupil gauge, how to obviously be able to measure pupils in millimeters. Now this is one of the ways you're testing part of the 12 cranial nerves. You're going to see if the patient can move through the various ranges of ocular motor, the fields of vision. You typically have a minimum of 6, up, down, left, right. Okay, I usually break it into 8. What I do is I do like a sign of a cross. I have them follow my hand up, follow my hand down, follow my hand left, follow my hand right. And then I want to see if they've got the upward left, upward right. So then I impose an X over that cross I just did. And I have follow my pen, to the upper right and then down to the lower left, and then I go back to the midline, and then I go to the upper left and then down back to the midline and down to the lower right. And that moves them through all of the fields of vision, and it lets you know that you've got proper eye movement for ocular motor. Okay, neuromuscular status. Like I said, you might have to elicit pain. I'm not a fan of the sternum rub. I would rather just take a pen. Now take your pen. Take a pen or a pencil and place it against your nail bed, okay? And then gently push down on that pen or pencil on your nail bed. I guarantee you in a few seconds you're going to say, ow. And you're going to be like, wow, why did he talk me into that? Well, most people will, and when you do that, will pull their hand away. It's a natural reflex because they move away from the pain. That means, and if they do that, they respond to painful stimuli. Decorticate and decerebrate posturing. Now look on page 487, top right-hand corner, you'll see a picture. And let's see if it's on the next one. Here we go. Decorticate posturing. The telltale sign here is look at her arms. See how her arms curl into her body? Well, think about that curling into her core, right? So decorticate, her arms are moving towards her core. Now, that is bad posturing for a neurological deficit, such as a stroke. But what's even worse than decorticate is decerebrate. Now see how everything extends. Everything extends and flexes. So decerebrate, it's got an E, extension, right? Extend, decerebrate. Remember the E, extend. Decorticate to the core, decerebrate, extending. All right. Pupillary reaction. You always want to remember PERLA. Pupils equal round reactive to light and accommodation. Neurochecks when you're doing, you want to do neurochecks every 5 minutes. If you got somebody, that's a minimum. Okay, now it can extend out to every 15, but it all depends on the patient's status and clinical presentation. So, all right. Any changes, one of the best ways to determine if a patient has a change in their intracranial pressure, the first thing you look at is if their level of consciousness. And I'm not talking about them being unconscious or unresponsive. I'm talking about their level of consciousness altering. Having an altered level of consciousness. This can start with something as simple as anxiousness. People, you got to believe them when they're just like anxious and they're like something's just not right. And they're just feeling out of sorts. And they have an altered level of consciousness right from the get-go. What is the level of consciousness? Well, are they alert? Well, if they're no longer alert to themselves, person, place, time, situation, they start acting confused, they start acting anxious, you better start acting suspicious because something might be going on. All right. Remember, vital signs need to be analyzed, so therefore they really shouldn't be delegated out. And if they are, you still are required to analyze them and understand and interpret them and what they mean. Because just because someone gathers numbers, it doesn't mean that they know what those numbers mean. You do, and that's important for you to understand and you to act upon. Because if they have a pupillary response, it's always going to be a late response. That blown pupil, that, pupils unequal, Yeah, you see that stuff on TV. Oh, pupils are unlegal. Yeah, but that's a late sign. Those patients are unconscious. You want to catch them when they've got an altered mental status and their vital signs are changing. And that's when you want to get it. Now, here are some of the common nursing diagnoses. Obviously, you need to be familiar with them. Just go through them on your own. It's important. You guys will be utilizing these when you do your concept maps. Okay, so it's important for you to know them, be familiar with them. All right. Okay. Now, when people lose their orientation, you have to reorient them. When people become confused, you need to clarify for them. Never play into any hallucination or dementia. Always orient the patient back to person, place, and time. All right, and then of course you have aphasia. You have different types, receptive, expressive, or a combination of the two. Receptive aphasia is difficult interpreting written or spoken communication. Expressive is when a person has difficulty expressing themselves in speech or writing. So one is a interpretation and reception. The other is an expressive. You need to know the difference. Of course, they can always have a combination of the two, global. So make sure you're familiar with this. And that wraps up this presentation, and I hope it worked for you. I hope you enjoyed it, and during this trying times, I'm going to try to reach out on a regular basis. Take care.